And hello, everybody. My name is Kevin McKenzie. I am working with the Baylor College of Medicine Children's Foundation in Tanzania. So today I'm going to talk to you about this topic of low-level viremia. I think it's something that a lot of us deal with in our daily practice, especially if you're working in the developing world. Tanzania, we have an interesting situation where the level of what we would consider virologic failure is at one level, and what we would consider stable is at a different level. And so I think many of us are often challenged and frustrated by the difference between the thought of what is considered virologic failure in the US or in Europe is much different than what we deal with in the developing world. And so why that is, and does that matter? So this study helped to kind of hopefully forward that discussion. So I have no disclosures. So as I discussed, the cutoff of 1,000 is something that we often use, but what we are seeing a lot of, mostly in adult literature, but more and more in pediatrics, is that low-level viremia, and again, the definition is varied. Here we'll say between 50 and 999 copies per milliliter is a risk factor for failure, subsequent failure of treatment. And as I said, there are few studies in children and adolescents of low-level viremia. So one of the benefits that we have in Tanzania is a large number of patients, a large number of children, and we do consistent viral load screening. Now, obviously, this is a challenge in many regions, and even for us, once a year, it's hard to collect enough data to be able to do this work. But we've, over the years, been able to accumulate quite a number of viral loads, and so this kind of research is becoming easier. And so this study dealt with children and adolescents living with HIV up to 19 years of age. They had to have been on antiretroviral therapy for at least 6 months, and this is up to July of 2021. And what we did for this methodology, trying to use low-level viremia and not problems with adherence or problems with mutations or resistance, is looking at all of the children who had a less than 50 copies viral load, and then the two subsequent viral loads after that one. So the child had to have at least 3 viral loads for it to be included in this study. And so here are the participants. So we started out with 1,719 children, and the final outcome assessment included 670. So looking at those 670 and the characteristics, so a bit more than half were female. Majority of the group was between 5 and 14 years of age, but we had a variety of throughout the age groups, and most were enrolled after 1 year of age, but again, a good variety. The age of art initiation mean was in months, was 48 months, or about 4 years old. WHO stage, most were stage 3 or stage 4. Very few had malnutrition, though it's something that we deal with a lot at my site, malnutrition. Caregivers were a variety of different things, but mostly parents. And the regimens, at this time, mostly PIs we were using in the smaller children, and dolutegravir for the older children. This situation has changed recently. About 10% had tuberculosis. CD4 count actually was quite good, with only less than 1% being in the severe category. ART duration. Many were on for 1 to 5 years, and the baseline CD4 count, or baseline viral load for them, most was actually suppressed. Okay, so looking at the outcomes of the study. So over the course of the study, so about half experienced low-level viremia, and you can see that we actually looked at the low-level viremia in categories as well. So 15 to 200 and 200 to 399, 400 to 999, and it was a good spread, though most within the 50 to 199. Okay, and looking at the outcomes, so this is taking all low-level viremia and comparing it to suppressed, and so what we see is that there's quite a spread between the outcomes, and this was found to be statistically significant. Then looking at the different categories of low-level viremia here, and so the very lowest blue line is no low-level viremia, and the one above that is the 50 to 199, above that in green, 200 to 399, and then in the orange, 400 to 999. So you can see that, again, this was statistically significant, and there was a good spread between the different categories of low-level viremia. Okay, so looking at the hazard ratios then, so you can see there that in the adjusted hazard ratios for all of the different categories of low-level viremia, so you can see that it actually spread out quite nicely, where the hazard ratio increased as increasing levels of low-level viremia. Age, you can see that there was a slight bit of significance in the 10 to 14 year range. Gender was not found to be significant. Nutrition status only in the unadjusted. Tuberculosis was not, and WHO stage for the most part was not. The regimen, interestingly, was only found in unadjusted, but in the adjusted was not found to be significant. And then for immunosuppression, for severe immunosuppression, was found to be significant even in the adjusted, but again, our numbers were quite small for that one, so the caveat to that. So in conclusion, low-level viremia is we had found to be associated with increased amount of virologic failure, and it depended on the level of low-level viremia, higher viral loads corresponding to higher risk. Age and immunosuppression were also associated with increased risk of virologic failure. Thank you very much.